All right, so good morning. And again, we're going to do transesophageal echo this morning. It's about 2 to 3 lectures. We're going to look at the indications for TE, contraindications, how to prepare the patient, the equipment setup, the views, and then the variant pathology that we can see with the transesophageal echo. Um, Most of you guys would have some experience with TEE, so you should be able to follow the lecture clearly. All right, so when we say transesophageal echo, what are we talking about? So, you know, what we do, we pass an endoscope. So we pass an endoscope into the esophagus, but at the end of this endoscope, you have a camera, okay? And the frequency of these probes are pretty close to 7 megahertz. So it's an ultrasound probe which is passed into the patient's esophagus, and the frequency of the probe is about 7 megahertz. This allows what we call superior visualization of the posterior cardiac structure. So if you remember, the esophagus lies just behind the heart. So by doing this technique, we can see the posterior structure of the heart very clearly, because remember, the camera is at the tip of the endoscope. So if the patient is positioned like this, the head of the patient is right here, the esophagus is here, and then just above the esophagus is the heart. Okay, so you intubate the esophagus, and the probe goes into the esophagus, so that you can see the posterior structure of the heart very, very clearly, unobstructed, so to speak. So it's another orientation. The esophagus is right here. The heart is in front of the esophagus. And then this is your probe. And the probe goes into the esophagus. The camera is right on the tip. And you can see the posterior structure of the heart very, very clear. Okay. What are some of the indications for doing a transesophageal echo? Why would you want to do a transesophageal echo? And one of the more common indication is cardiac source of emboli or clot. So if the patient had a stroke, CVA, and you don't know where and we deem it to be an embolic stroke. That is a blood clot traveling from somewhere and going to one of the blood vessels in the brain. If we can't readily identify where it's coming from, then the heart is usually one of the source for blood clots. So you'll do a transesophageal echo to look at the inside of the heart closely to see if there are any thrombus clots. One area where clots reside is in the appendage, the left atrial appendage, especially if the patient have atrial fibrillation or atrial flutter. If the patient have atrial fibrillation, atrial flutter, clots usually live inside the atrial appendage because it's like a cul-de-sac and you don't have good circulation of blood there, especially in atrial fibrillation. So that's one of the areas that you'll find blood clots. You can also find blood clots in the apex of the heart, other areas, but the most common location is in the left atrial appendage. So if you're looking for cardiac source of embolus, valvular endocarditis, so especially the mitral valve, Um, so if the patient have evidence of endocarditis, or if you're not seeing a valve clearly, say the mitral valve or the aortic valve clearly, and you think there may be an infective uh, mass, a vegetation, then a transesophageal echo is indicated because uh, the transesophageal echo allow you to see much smaller uh, vegetation than say your transthoracic. So you can see structures 3 millimeters or less with your transesophageal echo. So if you're looking for valvular vegetation and it's not clear on your transthoracic, then a TE is indicated. If the patient also have endocarditis and you think there's complications such as abscess or fistula, then a transesophageal echo is indicated in that thing. So again, for cardiac source of emboli, left atrial appendage, um, prosthetic heart valve dysfunction. So if the patient have, say, aortic around a mitral, if the patient have a mitral bioprosthetic or mechanical prosthesis, and you're looking for clots or vegetation, the transesophageal echo is a good method or good technique to use. When we talk about cardiac source of emboli, also if the patient has, say, a patent foramina navale or atrial septal defect, your transesophageal echo is a very good technique to evaluate for that. Aortic dissection. So aortic dissection is when there's a rip, there's a tear in the wall of the aorta, and it can go all, it can start anywhere. But if it start proximal, that close to the valve, it can go up to the ascending aorta, the arch of the aorta and descending aorta. So you can quickly do a transesophageal echo and determine if there is an aortic dissection. So transesophageal echo can help you in that area as well, and it's one of the technique to quickly make that assessment, aortic dissection. Um, a lot of surgeons who doing cardiac surgery will not do the surgery unless they have a transesophageal echo assistance. So if they're doing any type of valve surgery, say they're doing a mitral valve replacement or repair, they will do it on the transesophageal echo guidance. Even some surgeons doing regular coronary artery bypass surgery, if they're doing coronary artery bypass surgery, they will also do it on the transesophageal echo guidance. So, in cardiac surgery, the TEE is a very important part of the procedure. Patients with mitral regurgitation, if they have a little bit more than mild mitral regurgitation, it's sometimes mandatory for you to do a transesophageal echo to determine the mechanism of the mitral regurgitation, what's causing the mitral regurgitation. So a transesophageal echo is crucial in that area to determine the mechanism of the mitral regurgitation, what's causing the mitral regurgitation. So anything more than mild mitral regurgitation, that's also an indication. Suboptimal transthoracic echo. So you're doing your regular transthoracic echo, TTE, and if the images are not very good, you can move on to a transesophageal echo. That's another indication for doing a TE. Intracardiac masses, such as your left atrial myxoma, or if you think the patient have, a clot or any type of mass in the cardiac chambers, then a transesophageal echo is indicated. So those are some of the more common indications for doing a transesophageal echo. What about the contraindications now? When should you not do a transesophageal echo? So you should not do a transesophageal echo in some patients. And if the patient have any esophageal problem in the esophagus, because remember, you're going to put the probe in the esophagus. So if the patient having a significant problem with their esophagus, you don't want to do a transesophageal echo. So we divide the contraindications into absolute and relative contraindication. So the absolute contraindication, esophageal spasm. So if the esophagus goes into spasm, you don't want to do, the transecation. You can cause trauma. If the patient have esophageal stricture, severe narrowing, you don't want to do it. Esophageal laceration, you can make it worse. You don't want to do it. If the patient have esophageal perforation, you don't want to do it. If esophageal diverticular, you don't want to do it. So these are the absolute contraindications. So if the patient have any pathology in the esophagus, you don't want to do your TE. So these are some of the relative contraindications. You can do the procedure, but the benefit have to outweigh the risk. And so some of the relative contraindication, patients has a large diaphragmatic hernia. That is, there's a weakening in the diaphragm, and the stomach is now into the chest. So it's a relative contraindication. If the patient comes in with what look like an aortic dissection, and you want to determine whether the patient needs to go to surgery ASAP, then you can take the risk. You can accept the risk and do the procedure. Cervical disease, patient have problem in the neck, the vertebrae in the neck. Sometimes you can't extend the patient head, because you have to extend the patient head in order to do this procedure. Upper gastrointestinal bleeding, you have to think twice, because if the patient have, say, a varices, you can knock off the clots and cause torrential bleeding. So remember, varices is just these dilated blood vessels in the lower esophagus, usually in patients with cirrhosis of the liver. So you want to think twice. Dysphagia, that is difficulty in swallowing. If the patient have present with symptoms of dysphagia, it might suggest that there's some pathology in the esophagus, a cancer, and you put the probe in and you cause perforation and torrential bleeding, or odynophagia, which is just pain on swallowing, may suggest pathology as well. So these are relatively contraindication. The benefit should outweigh the risk. So how you prepare the patient for these procedures? How do you prepare the patients? All right, so what you do is the patients should be kept NPO, nothing to eat, closer to 8 hours, because you're putting a foreign object in the patient's esophagus. It's gonna there's a tendency for the patient to retch and vomit. And if they vomit and aspirate, then that's a problem. That's a complication that you don't want. Okay? So preparing patient for this procedure, they should not eat anything for between 6 and 8 hours, closer to 8 hours. Okay? You have to explain the risk versus the benefit. You have to get a consent. So this is an invasive procedure, so a consent should be obtained. You have to explain to the patient what you're going to do, the risk involved, and then they have to sign the consent. If the patient have dentures, false teeth, you have to remove them, because you you can dislodge these and the patient can swallow the dentures. So you don't want that. You need to have a large IV in the patient's antecubital vein. Okay, so probably gauge 20 and above. If you can get an 18 gauge, that would be probably preferential. So you need to get an intravenous line in the antecubital vein. You should not do the procedure unless you have a monitor. You should be able to monitor the ECG continuously. You should have the ability to check the patient blood pressure, and you should be able to do pulse oximetry. So if you don't have these things in place, you shouldn't do a transesophageal echo. You need a cardiac monitor that's gonna give you ECG. You need blood pressure assessment periodically, pulse oximetry, okay? And then you should sedate the patient. Some people do transesophageal echo without sedation, but it's probably inhumane. You should sedate the patient somewhat. You should have suction apparatus, because the process of putting in a probe in the esophagus can cause a lot of secretion and stuff, and you don't want the patient to aspirate again. So you should have the ability to suction. So suction apparatus should be available. You should anesthetize the patient throat with either lidocaine or lidocaine. These are numbing medications that you can use to reduce gagging. Okay, you don't want to sedate you don't want to anesthetize the area too much, but you should 1 or 2 sprays. Okay, so those are the indications, contraindication, patient preparation for the procedure. Now, you have to be familiar with the views, though. So transesophageal views are somewhat different from your regular transthoracic views. And we're going to go over some of these views. We're going to use the Toronto General images to go over some of these views. Okay, let's see. More on the contraindication, the potential contraindication complications is the potential complication that is less than 1%. So it's not tremendously high, but this is an invasive procedure, so you can cause trauma to the patient. So the potential complication is less than 1%. So some of the complications that one can get is what we call laryngospasm. So when you put the probe in the esophagus, just as you put in the probe in the esophagus, the larynx can go into spasm and the patient can become hypoxic. That is, the oxygen level can fall very low, and that is the reason for your pulse oximetry. So you have to put the pulse oximetry on to monitor the oxygen level in the patient, because they can develop laryngospasm. They can have throat pain in the throat, because you're putting in this probe and you can traumatize the patient's throat, so they can have pain. They can have shortness of breath. Okay. Very important is methemoglobinemia. So you need to pay special attention to this, because this is what they're going to put on the exam. Okay. the patient can develop methemoglobinemia. And remember, we use a spray to numb the back of the throat. We talked about cytokine spray, hurricane spray, benzocaine. If you use benzocaine, the patient can develop what we call methemoglobinemia. And I'll explain that a little bit more to you. They can also aspirate. So let's talk a little bit about methemoglobinemia. So you have hemoglobin circulating in the blood vessels. The red blood cells contains hemoglobin, and the hemoglobin, as the name suggests, hemoglobin contains iron. But the iron that's in the hemoglobin is Fe2 plus, the valency of 2. So it's Fe2 plus, which is circulating in the hemoglobin. Okay, so the red blood cells contain the hemoglobin, and the iron in the hemoglobin is Fe2 plus. When you use this benzocaine, you can convert the Fe2 plus to Fe3 plus. So it's still iron, but iron with a valency of 3. The problem with that is that those iron, when they bind oxygen, they don't give up the oxygen readily. Remember, the purpose of hemoglobin is to transport oxygen, and when it gets to the tissue, it's supposed to give up the oxygen freely, because the tissues needs oxygen to manufacture energy. But the problem with methemoglobinemia, where the iron is converted from Fe2 plus to Fe3 plus, that hemoglobin do not give up oxygen. So even though the patient is breathing okay, they're hypoxic because the tissues are not getting oxygen. And that's what we call methemoglobinemia. And if you use the benzocaine spray, that can result in methemoglobinemia. Patient can aspirate as well. You can get hypotension, blood pressure falling too low, or you can get hypertension, patient blood pressure increases. Tachycardia, rapid heartbeat. You can traumatize the esophagus, causing esophageal rupture. So you can rupture the esophagus. You can have, and very rarely, it can result in the patient demise, death. Okay. So when we're doing this procedure, of course, you have to keep the patient NPO, explain the procedure to them, you let them sign the consent. They come in, you put them on the monitor, you measure the blood pressure, no, you don't have to give them oxygen, but you put your blood pressure cuff, you monitor blood pressure every 5 to 10 minutes, continuous ECG monitoring, you have your suction equipment set up, and then you have to use certain medications. So you can put them to sleep. We usually use midazolam, Versed. So we put them to sleep. I mean, don't put them completely out. The patient shouldn't be completely out. Put them to sleep a little bit. You should have the ability to reverse this medication though. So you should have, we usually use romazicon to reverse the midazolam, the Versed. So it's a reversing medication. Some people use fentanyl or Demerol. All right. So when we talk about left atrial appendage thrombi, so this is whenever you see a semicircle along with a study, it's probably transesophageal echo, and you can move from 0 degrees to 180 degrees. Okay. And then this is the left atrial appendage. Left atrial appendage is right here. You can see this nice circumscribed thrombus. This is actually a patient that we did. This patient, she presented with atrial fibrillation, and we were gonna convert her to sinus rhythm. But when we did the transesophageal echo, she had a nice big clot in the left atrial appendage. We just anticoagulate her and abandon the procedure. So she would be ready for cardioversion about 4 to 6 weeks. But she has a nice left atrial appendage thrombi right there. Okay, this is another patient of mine who had a left atrial myxoma. You see this nice big, but this is a trans. You don't see any semicircle there, so this is a transthoracic echo. But we saw this as this patient presented with a stroke. She presented with a stroke, and we saw what looked like a mass there. And then we went on to do a transesophageal echo to further delineate what was going on. Okay. Okay, so this is another patient of mine who presented with she presented with a heart attack, but she was febrile. She was sort of what we call a septic. So heart rate is pretty rapid at first and stuff like that. But when we did the transthoracic, and we weren't clear what was going on, but when we did the transesophageal, so the semicircle 0 degrees, she had endocarditis, and she had vegetation not only in the mitral valve but also on the aortic valve, and a piece of that vegetation on the aortic valve embolized into her coronary arteries, and that's how she got the heart attack. So, and she did. We treated her with antibiotic, and she did very well. So this is a vegetation on the posterior mitral leaflet. This is a patient with dissection. So this is the aorta, and you can see that there's a membrane inside the aorta. So the wall of the aorta ripped in two. If you put color flow, you can see flow in one and no flow in the other, or low flow in the other. True lumen, so aortic dissection. What I'm gonna do is, okay, so this is the American Society of Echo training session or teaching session for transesophageal echo. So again, the probe is in the esophagus, which lies just behind the heart, and you can image the heart. You have what we call, so you're going to see where we have the upper esophageal. So upper esophageal is when the probe is in the upper portion of the esophagus, and then mid esophageal when the probe is in the mid esophagus, right there. And then gastric is when it's in the stomach, and then deep gastric is when it's in the much deeper. So there are actually 4 positions you can insert the probe. You can have the upper esophageal, the mid esophageal, transgastric, that's in the stomach, and then deep transgastric. And then these are the different levels that the probe will be positioned. And so when you have the probe in the esophagus, you can flex it, and if you just push your index finger out, when you flex it, then your index finger comes up, and that's how the probe goes. The probe's sort of it moves up. So when you flex it, the probe moves up, and then so that's flexing, and then retroflexion is when it goes backwards. So you can move the probe. So if the probe, say the probe is here, and you can let the probe point upwards, and that's what we call flexion. And then retroflexion, you move it backwards. So the probe, you have on the angle of the transesophageal echo, you have these controls, and you can flex the probe, and you can retroflex the probe. You can move the probe from side to side, just like that. You can move it from side to side, or you can rotate. You can physically rotate the probe, or remember we said that there's a semicircle on the side of the transesophageal probe. You can move the angle of the camera. Okay, you can vary that angle from 0 to 180 degrees. Okay, so um, so you have to have a basic understanding of the orientation, what's going on. So again, the semicircle, you go from 0 degrees to 180 degrees, and in the mid esophageal, you're gonna get structure looking like this. Okay, this you're going to get a structure looking like this, where the left atrium is right there, the left ventricle. So this is the mitral valve. Left atrial appendage is right there. You can see a little portion of that. The uh, ventricular septum, the right ventricle, tricuspid valve. Okay, if you move the angle of the camera to 90 degrees now, then you get you get this view looking like a so the first view is what we call a 5-chamber view. Okay, um, so let's see if we can play that, and then if you move it through 90 degrees, you get something look like this, where this is the inferior wall and the anterior wall. So because of how the probe is positioned, this is not your anterior wall, this is your inferior wall. And then this is going to be your anterior wall, left atrium, of course, and your left ventricle. Let's see if we can play it. All right. Okay, we don't want that. All right. All right. So let's, so it's not gonna play, but that's okay. Um, so so this is angle 0 and angle 90 degrees. Okay. So that's in the mid esophageal level. And then if you go to 180 degrees, so what was on the left side now goes to the right side, and what's on the right side goes to the left side. That's all that means. So when you move it from 0 to 180, you get the opposite picture. So the mid esophageal level. Okay. All right. And so these are some of the common views. So again, in the mid esophageal level, 0 degrees, or 90 degrees. And so when you look at the actual image, you'll get something looking like this or this, okay? So again, at 0 degrees, your left atrium is there, left ventricle is right there. You may or may not see a portion of the appendage. Okay, right side is over there. 90 degrees, you get left atrium, left ventricle. So, this is like your 4-chamber view or 5-chamber view. Okay, mitral valve. Okay, this is the anterior leaflet, posterior leaflet. And then with your so-called 2-chamber view, remember this is your inferior wall, your anterior wall. Okay, and then if you vary the angle, not 90, but a little bit less than 90, then it's a modified sort of 2-chamber view. Your left atrium, left ventricle. At about 125, 130 degrees, say or 130, 135 degrees, you get your nice long axis view. You can see the aortic valve, you can see the aortic root and the ascending aorta, the anterior mitral leaflet, left atrium, posterior mitral leaflet, and left ventricle. So this is a very important view. So it's about 130, 135 degrees. Okay. So this shows you the degree that you do your rotation. So you can look at, pull out a transesophageal echo probe, and you can look at the controls, and you can see where you can, the big knob on the side flexes the probe. It can anti-flex it or it can retroflex it. Anti-flex is when it moves upward, retroflex is when it moves backward. And then the small probe on the side, move it from the probe from side to side. And then there's a little knob on the top of it. When you press it, you can vary the degrees. Okay. All right. So still in the mid-esophageal level, at 90 degrees, you again you'll get your anterior wall, your inferior wall, and if you move it to 180 degrees, you just flip things around. So at 135 degrees, 130, 135 degrees, you get your aortic root to your aortic valve and stuff, and you can see that clearly. Okay. You're gonna hear mention of scallops, and when we say scallops, is the mitral valve have areas that we call scallops. It's just different section of the mitral valve. We're not going to go into that in any detail right now, but just remember that it has scallops. All right, so mid-esophageal level. So mid-esophageal level is right there. You get a sort of 4 or 5 chamber view of the heart. Yeah, the left atrium, left ventricle. So in this view, when you're looking at the heart, you can see the left ventricle flow tract. You can see the left atrium. You can see the left ventricle. You can see a portion of the right ventricle, the ventricular septum. Okay. And you can eliminate the aorta and just get your 4-chamber view, mid-esophageal level, left atrium, left ventricle, right atrium, atrial septum, ventricular septum. And then at 90 degrees, you get your so-called 2-chamber view, where you'll see your inferior wall, anterior wall, left atrium, left ventricle. See it over there. You can see what the coronary sinus, which is right there as well. Okay, so you're still in the mid esophageal area at 90 degrees. And if you rotate your probe a little bit, I mean, you still get this is anterior wall, inferior wall, left atrium, left ventricle. Um, and if you manipulate it a little bit, you can see the left atrial appendage. So that's one view that is important. So you can see if there's any blood clots in the left atrial appendage. Still at your mid esophageal level, at say 130, 135 degrees, then you can get your aortic valve, your aortic ascending aorta, the anterior mitral leaflet, posterior mitral leaflet, left atrium, left ventricle. So you have to know the different structures. You have to know, because what they're going to do is they'll put a vegetation in some place and you have to identify where it's located. So you have to know the structure that you're looking at. Okay, so 130, 135 degrees. If you just rotate the probe a little bit, then you can see more of the aortic root and the ascending aorta. Very important if you're looking for dissection. So, okay. And then if so, if you're in your transgastric location, you straighten your probe and you rotate it 180 degrees. Now you see the aorta. This is a cross section of the aorta. And then if you just pull your probe up or push it down, you can follow the entire length of the descending aorta to see if there's any dissection. Okay, so you can either get a short axis or a long axis of the aorta. Um, so you can look at the ascending or the descending aorta. So what I normally do is when I'm in the gastric, the transgastric location, straighten the probe and rotate it 180 degrees, and you will see the descending aorta. And then if you pull it all the way up, you will see the entire descending aorta. And then when you're in the upper esophageal location, you can see the ascending aorta. So that's important. All right, so this is still mid-esophageal level. Okay, so the probe is right there. You can angle it to look at the ascending aorta and the superior vena cava. Okay. Um, when you're in your mid-esophageal location, say at about 80 degrees, 75, 80 degrees, you can get your nice, short axis view of the aorta. So be very familiar with this view, short axis view of the aorta. So this is going to be your left atrium right there, left atrium, your atrial septum, and this is your right atrium, okay? And then this comes into your your right ventricular flow tract, and then your pulmonary valve will be someplace right there. Very important, okay? Very, very important. This is your atrial septum. Atrial septum is right there. So adjacent to the atrial septum is your non-coronary cusp, okay, of your aortic valve. So still at about 80 degrees. If you manipulate the probe a little bit, you can see more of your left atrium right there, atrial septum, right atrium, your right ventricular flow tract with your pulmonary valve right there. Your pulmonary valve is right there. Okay. Your atrial septum, this would be your non-coronary cusp. This would be your left coronary cusp, and the right is right there. Okay. So be familiar with these views. And then this is another view, still mid-esophageal level, but you looking more at so your left atrium. This is the atrial septum and right atrium. You get a much clearer view. Okay. So if you are looking for something at the on the septum, atrial septum, you can see it clearly. And this is what we call your so-called bicaval view. This is your bicaval view where you can see your superior vena cava and inferior vena cava. So bicaval because you can see both views. And then your left atrial appendage. Remember, that's a very important view. So with the left atrial appendage, you can see it multiple. You can see it in the mid-esophageal location of the probe, and then this is your nice left atrial appendage, or you can see it in the gastric. But you have to see the left atrial appendage to see if there's any blood clots there. And then when we say transgastric now, the probe is, you insert your probe lower down into the stomach and you flex the probe. That means you if you take your index finger and bend it forward, that's what we call antiflex. So you antiflex the probe and you're going to see something looking like a short axis like this. Looks like a short axis, okay? And then if you pull it back a little bit, you get a nice short axis, okay? Nice short axis. So this is your anterior wall here, and this would be your inferior wall. So it's a little bit different from your transthoracic because of how the probe is located. And of course, these are your papillary muscles. So if this is your inferior wall, sorry, if this is your anterior wall, then this is your anterior lateral papillary muscle. And then this, if it is your inferior wall, this is your posterior medial papillary muscle. Okay, all right. So this is your transgastric, and you can just pull it and manipulate it a little bit. So what I was saying to you, when I have the probe like this and it's retroflex, it's flexing up, it's going upwards to get the aorta. Now I straighten the probe. I just straighten it, okay, and then rotate it from this position. I rotate it all the way around. I physically rotate it. I physically rotate it to get the aorta, okay. Hopefully I'll get to demonstrate to you guys how it's done. But I physically rotate it all the way around and get the aorta from that position. Okay, so this is what I'm talking about. So when I'm in the transgastric view, I straighten the probe, straighten it all, and then physically rotate the probe all the way around. Then I get a nice aorta. Okay, I can do the long axis, so this is a short axis. I can do the long axis, and it's just varying the degrees on the camera to get to. So if this is 0 degrees, I just put it 90 degrees. So I move from this nice short axis to the long axis, and then you can put the color in to show that blood is flowing, there's no dissection, that type of thing. So that is it. So again, your 4-chamber view, left atrium, left ventricle, the anterior mitral leaflet, you see, okay, a 2-chamber view. Okay, this is you're looking at your aorta, 135 degrees. You can see a nice aortic valve, ascending aorta, left ventricle, left atrium, anterior mitral leaflet, posterior mitral leaflet. Okay, so you can go over this on the American Society of Echo website. Be familiar with it. In your lecture series, you have these. You have the pictures of them. So go over that. Be familiar with it. Okay, again, this is just highlighting how, because this is, they're gonna ask you this, okay? They they're gonna ask you to label the coronary, the interatrial septum, non-coronary cusp, the left and the right. You're gonna get that on your exam because they love it. Okay, anatomy, they love anatomy. So I say just go over it. Be familiar with the structures. Be familiar with the anatomy. So because all they're going to do is put a structure somewhere and ask you to say where it's located. And so you just have to know the different structures. So again, when you get this view, this is the mid esophageal level. Your left atrium is right there, atrial septum, right atrium. Then come into your tricuspid valve is right there. Then your right ventricular outflow tract. This is your pulmonic valve and a pulmonary trunk. Okay, so if this is your atrial septum, non-coronary cusp is right there, the left coronary cusp, and then the right pulmonic valve is right there. So some views they're gonna automatically give you and expect you to know. All right. All right. So